right, welcome to your first antepartum content mini lecture. We are going to talk about some initial assessments that we do with the pregnant woman when she discovers that she is pregnant, and what some of the normal expectations that she can be informed of that will happen at her antepartum or prenatal visits throughout the pregnancy. So a little bit of review. If we remember that the pregnancy is divided up into trimesters. So we have 3 trimesters. First trimester is from conception through the end of the 12th week. Remembering that gestation is always calculated in weeks and days. So through 12 weeks, 6 days, that's the first trimester. Second trimester starts at 13 weeks and continues through the 26th week. And then third trimester starts at 27 weeks and lasts until delivery. We expect most pregnancies to go the duration of 40 weeks, upwards of 42 weeks from conception, and remembering that anything past 37 weeks is considered term. So we have 3 categories when we talk about signs of pregnancy: presumptive, probable, and positive. And a lot of students, this is new information to, because some things that we as the general population think, oh, that must mean someone is pregnant, are actually not positive proof diagnostic of pregnancy. So the easiest way to keep these straight is presumptive is the subjective measurement. So the difference between presumptive and probable, if you remember that presumptive has the S and probable has the O. So subjective, objective. Presumptive signs of pregnancy are the subjective reports from the patient that she subjectively tells you are happening that make us think she is pregnant. So for instance, a subjective report from a patient that is a presumptive sign of pregnancy would include amenorrhea or absence of a period. They've missed a period, skipped a period. We know this is a presumptive sign and not proof of pregnancy because other things can cause a patient to miss a period or have a late period, such as hormone imbalances or excessive stress, excessive exercise, weight loss, etc. Probable signs of pregnancy, so our O is in there, are objective signs of pregnancy. This means this is examined or observed by an examiner. So a healthcare provider, a nurse, a physician, etc., observes these signs of pregnancy, and we can see them objectively. This could be, for instance, a growing uterus. If we measure the uterine size and it is increased from our normal non-gravid, non-pregnant uterus, that is a probable sign of pregnancy. Another one of these would be softening of the cervix or Goodell's sign. When we do an examination, that is indicative of pregnancy. However, those things can also be caused by things that aren't pregnancy. So it's still not proof of pregnancy. Positive signs of pregnancy are proof. They are diagnostic. Nothing else could cause these signs other than the pregnancy itself. This would be fetal heart rate being auscultated, ultrasound and visibility of the fetus in the uterus, fetal movement that can be observed by an examiner. So not just fetal movement reported by the patient, but an objective examiner could put their hands on the abdomen and feel fetal movement. Those are positive signs of pregnancy. Okay, so 3 categories: subjective reports, objective reports. Both those presumptive and probable signs can be caused by something else. And then positive or proof diagnostic of pregnancy is our 3rd category. Naegele's rule, as you might have reviewed in your textbook, is used to calculate the estimated due date or estimated date of confinement. These terms are used interchangeably. They both mean when baby is due to be born. We calculate this using the first day of the patient's last menstrual period, or LMP. And we add 7 days and subtract 3 months, and that gives us our estimated due date. So for example, if the first day of the patient's last menstrual period was September 23rd of 2020, we would subtract or add 7 days, subtract 3 months, and we would come up with June 30th of 2021. Now, it doesn't really matter which of these you do first, whether you subtract the 3 months or you add the 7 days, it's going to give you the same answer. But it's easiest to shift your day first and then calculate your months. My suggestion for this would be to transpose your month into the number of the month, so you don't skip months when you're trying to count between them. So we know that September is the 9th month. We subtract 3, that gives us the 6th month. The 6th month is June. Routine prenatal visits. So we talk about how often or how frequently we expect to see moms during pregnancy. Now, I'm going to give you the recommended schedule for a low risk pregnancy. We would honestly and obviously increase the frequency of visits if there is high risk, if there's concern, if there's abnormal findings, etc. But for a typical, normal, routine schedule, up until the 28th week of gestation, so for the first 2 trimesters, if you think of it that way, women are seen every 4 weeks or monthly for their prenatal visits. After they hit 28 weeks, up until the 36th week, they're seen every other week, every 2 weeks for prenatal visits. And then from 36 weeks on until they deliver, they are seen weekly. Again, this is the routine expectation. If they are high risk, if there are problems, if there are abnormal findings in their assessment, we would absolutely increase the frequency that they are being seen. And more than likely, they would also probably qualify for fetal monitoring or in more close testing of the baby via either ultrasound or NSTs, etc., fetal monitoring, given their risk factors. So what do we do at prenatal visits? What are we looking for, right? So this is a not completely conclusive list, but this is mostly common of what is done at prenatal visits. We do the patient's vital signs, close monitoring of their blood pressure and any changes because of the risk for hypertensive disorders in pregnancy and how that affects both mom and baby. We obtain the patient's weight. We have a normal weight range that we expect patients to fall within and how much to gain during pregnancy. It is a risk factor for patients to gain too much weight during pregnancy. It's also a risk for them to gain too little weight, so we pay close attention to that. We do a urine dip on every visit, looking specifically for protein and glucose, protein linking to hypertensive disorders and glucose linking to gestational diabetes. It is normal for pregnant women to have trace protein and glucose in their urine during pregnancy because of the physiological changes in the body, but anything more than trace would be concerning. We do a fundal height in centimeters. A fundal height is a measurement from the top of the symphysis pubis, or the pubic bone of the woman, to the fundus, the top of the uterus during pregnancy. We expect that measurement in centimeters would match their weeks in gestation. So for example, if a mom is 28 weeks pregnant, we would expect that her fundal height be 28 centimeters. Now, we don't get too bent out of shape if we're a week off one way or the other, but if there's a large discrepancy, if we think she's 28 weeks and we're measuring 32, we would look into why that is. So we get concerned whether it's too high or too low. We start to evaluate baby size, the fluid level, other things that could alter that number. Now, this is only accurate for singleton pregnancies. If they are carrying multiple babies, obviously that fundal height will be different than if they were carrying one. We assess the fetal heart rate via a Doppler. We start this by about the 8 to 12 weeks. We can hear baby's heart rate using a Doppler in the office. We expect that fetal heart rate to fall within our normal range, just like we would if we were doing external fetal monitoring towards the end of pregnancy. It is common in the very early weeks during that first or early second trimester for the fetal heart rate to be very high, sometimes slightly above that 160, but it would never be low. We do routine blood work looking at mom's blood type, her hemoglobin and hematocrit levels, the different prenatal labs, which we will talk more about in class. We do ultrasounds at some prenatal visits. Typically, there is an ultrasound during the first trimester near the 20-week mark for an anatomy scan, and then if necessary, more ultrasound assessments in the third trimester dependent upon risk factors. We give immunizations and or RhoGAM administration, remembering that if mom is Rh negative, she will require RhoGAM administration at the 28-week gestation mark. We offer Tdap booster vaccinations and flu vaccines to pregnant women. Right now, some providers are also providing COVID immunization to pregnant women. That is not a necessarily blanketed offering right now. It is more patient and provider specific, but I do see that being a new thing as we move forward with immunizations for COVID. Our 5 common assessments for all pregnant women. We assess pain, contractions, any leaking of fluid, vaginal bleeding, and fetal movement. Once mom has hit 20 weeks gestation, so once we've hit the halfway mark, we expect mom to feel some type of fetal movement. Now, early on around that 20-week mark, it's more like fluttering, but they feel something, and then that becomes stronger and more noticeable of actual fetal movement as she progresses in pregnancy. So not until the 20-week mark would it be concerning if mom doesn't report any fetal movement. Providing anticipatory guidance and education. So what mom can expect between now and her next prenatal visit. Important signs and symptoms to report as far as being abnormal, if she has any bleeding, if she feels like her water breaks, if she's having painful or rhythmic contractions, if baby isn't moving like normal. Signs and symptoms of preeclampsia or diabetes or those other complications that we sometimes have. Making sure that she feels supported and safe to call if she has concerns. Possible fetal monitoring if risk factors are present, especially once we get into that later second trimester or the third trimester. And then in any medication management. A lot of medications are compatible with pregnancy. Some are not and require some alterations during pregnancy. And then some medications need altered in dosage during pregnancy. For example, insulin. A patient who is very compliant and on a stable dose of insulin, once they are pregnant, their glucose demands are different, their insulin demands are different, and that will need altered moving forward. If it's a patient who has chronic hypertension, they could have a very stable dose of antihypertensive medications that they're on prior to pregnancy, but those dosages might need changed within pregnancy. So any medication management takes place there as well. And that is all for our mini lecture. And we will go more in depth in class on what to expect during pregnancy.